Dear colleagues, welcome to EHJ Today. I'm Filippo Crea, Associate Editor of the European Art Journal in Davos, at the Cardiology Update meeting organized by Tom Luscher. I'm sitting with Otto Smiseth, who is Professor of Cardiology in Oslo, and is one of the world leaders in myocardial straining imaging. Otto, I have a very initial simple question for you. What about the use of strain imaging in clinical decision making?
Well, first of all, I think strain imaging is probably the most important imaging we can do, if we can do it well. And today it's used somewhat. I use it myself when I do my patients, but there is still a way to go before it's ready for full implementation. So today, strain imaging is still undergoing testing and research work, but we are making big steps forward.
Well, but in your daily practice, of course, you are one of the leaders in this field, so it's a different perspective. But in your daily practice in particular, when do you use it for clinical purposes?
First of all, strain, the way we use it, measure shortening. So in a way, strain is a way to measure myocardial shortening and left ventricular contractile function. And there are several applications, but maybe the one which is the most important presently is to detect early stage of dysfunction. And one important example is patients who are undergoing chemotherapy for cancer. And we know that chemotherapy is very good for the cancer, the new drugs. We also know it's very tough on the heart sometimes. And when you do follow patients undergoing treatment for cancer with chemotherapy, it turns out that strain imaging is a very powerful means to detect changes which are important for how you manage these patients. There is still need for really randomized trials, but the early experience is very good.
And in your practice, if you find these early changes, do you suggest the oncologist to change treatment based on that?
No, we don't, very rarely, and I don't think maybe ever, we will dare to reduce the dosage of the chemotherapy. That could be dangerous. What we do is sometimes we use the strain imaging in combination with the conventional ejection fraction when we are evaluating patients, and sometimes we will add ACE inhibitors or beta blockers to protect the heart when the patient is undergoing chemotherapy. So it's used not as a standalone, it's used in combination with ejection fraction.
Another fascinating area are patients with suspected angina and the assessment of inducible ischemia in these patients. And we know that traditional echocardiography shows a good sensitivity, but we are not 100%. Do you think we can improve the identification of these patients with strain imaging?
I think we can. At the present time, strain is not really established as a method for selecting therapy or stratifying patients with coronary heart disease. But in single cases, if you are used to applying strain, you can get additional information which helps you. So, but yet it's need for a lot more work before you can say that strain imaging can be used for decision making when you have patients with chest pain. Not yet, but it's coming.
Another interesting area is the timing of surgery, of percutaneous approaches in patients with valve disease. This is a moving target. Do you think that you can foresee a role for straining imaging in the identification of the optimal timing for valve replacement or repair?
Yeah, there's work undergoing right now, and strain imaging, what is sort of the strain is in the way we use it, is shortening by a more sensitive measure than ejection fraction. And to find the golden moment for valve surgery is difficult, as you say. And the strain is at the present time not ready for implementation for that purpose, but I bet in the future it will be, because it picks up changes in the myocardial function much earlier than conventional echo.
You are mentioning very wisely that the technique is very interesting, very attractive, but a lot of work has to be done. Now, there are two types of work in perspective. One is validation in prospective trials. The other is technological improvement. What do you foresee in these two directions?
Well, first of all, the companies have to agree how to measure strain, because now we have different methods with different companies. They are doing that right now. Then they have to define the normal values, and then we can start doing the randomized trials. And the data so far indicate that strain imaging is more sensitive and is a better marker of prognosis than ejection fraction in patients with heart disease. But at the present time, it's a lot of very promising work. Furthermore, for arrhythmia detection, some work done in Oslo by Dr. Christina Haugo showed that in patients with long QT syndrome who had syncope or a cardiac arrest, she could, by looking into the strain imaging, she could identify the risks of getting cardiac arrest or ventricular fibrillation by strain imaging much better than conventional methodologies. It's a very promising area to find risk markers for death and cardiac arrest by finding the early changes before we get the big change with fall in ejection fraction. That's an important application of strain. And in this field, we have come quite far, actually.
Coming back to technology, do you foresee important steps in the improvement of this technology in the near future?
Yeah, first of all, it's about communication. When we say strain, we use a word from the engineering world, and cardiologists don't like that word. When I say, I call it shortening fraction or shortening. It's actually what we measure, or thickening by strain. So we should move from, I think, the engineering term into the physiology, cardiology term shortening. So strain measures very well myocardial shortening. That's the first step, term communication. Then we have to apply it and do the randomized trial to see if we apply strain to give treatment differently, if it helps on life quality and if it can save lives. That's going to be the next important step to implement the technology, not just for imaging, but for applying it in decision making. And there's some work going on within the cancer, chemotherapy field, but more is to come in the other parts of medicine.
In a global view, do you think there's more interest in the States or in Europe in this technology?
Well, the development has been both places. As far as I know, there might be more work, but Trondheim, Hans Torp, and Heimdal were the first to use the Doppler strain. Then came the speckle tracking strain, and speckle tracking is you sort of use the white dots in the image and track the motion. That is the future, I think. And the technology is improving. And I think we will need a couple of more years. Right now we have something which is good, but it can be even better. And then we have to get all this sort of collaborative work between industry and cardiologists, which is ongoing. So we are on the track, but it has taken a few years since we published the first papers. But interest is great. And I think we will get out of talking about indices and talking about helping patients to live longer and have better life quality. That's the next important step.
One last comment. If you have a suggestion to give to our cardiologist fellows, is wait and see or start practicing? Start practicing.
In fact, you may actually today have a good echo lab, a state-of-the-art echo lab without doing strain. But if you want to be part of the future, part of development, do strain. I do it in almost every patient, and I recommend to get that new insights which strain provides you. Do it whenever you can. Takes a few more minutes. If you have a good image, maybe only 3 or 4 more minutes. If you have a poor image, maybe a little bit more. But do it on every patient if you have the time.
Well, thank you for this very interesting conversation.